Welcome back to Radon's Smart Review Thoracic Edition.
Glad to be back.
So, imagine an adult patient walks into your clinic for a consult. You pull up their contrast-enhanced chest CT, and there's this massive tumor sitting right in the prevascular space of the mediastinum.
Always an intimidating scan to open.
Right. It's centered directly in the thymic bed, it's pushing aggressively against the major vessels, and it's resting heavily right on top of the pericardium. But here's the catch. When you walk into the exam room to take their history, the symptom that actually brought them in wasn't chest pain.
Let me guess. No cough either.
Exactly, no cough. It was the fact that late in the afternoon, they started seeing double, and their eyelids just felt too heavy to keep open.
Yeah, that clinical picture perfectly captures the unique challenge of these rare thoracic tumors. We are dealing with diseases that completely blur the line between structural anatomy and systemic biology.
Right, it's not just a lump in the chest.
Exactly. And the biggest danger here isn't usually, a failure to memorize some obscure genetic mutation. The real danger lies in sequence errors.
Sequence errors.
Yeah, I mean, clinicians often do the right thing, but they do it at the exact wrong time. Like, they'll biopsy a mass that should have gone straight to surgery. Or they just assume a patient who is medically fit for anesthesia automatically has a tumor that is anatomically resectable.
I have absolutely seen that happen. The pressure of dealing with an unfamiliar histology kind of pushes clinicians to act with this false sense of certainty.
They panic and apply generic lung cancer rules to a thymic space. And that space operates on completely different biological principles.
Which is exactly why our mission today is to build a repeatable, safe decision pathway. We're going to take that exact patient, the one with the drooping eyelids and the mediastinal mass. We're going to walk you through the workup, staging, surgical decision-making, post-op radiation, and surveillance.
Let's start right at the beginning with the workup, because long before we even utter the words radiation fields or talk about systemic therapy, a prevascular mass is it's what we call a compartment diagnosis.
Because the mediastinum is incredibly crowded.
Exactly. You have to rule out the other residents of that compartment. If you're looking at a mass in the anterior space, you have to actively prove to yourself that this isn't a lymphoma or, a mediastinal germ cell tumor.
Or even just a substernal goiter pulling down from the thyroid.
Right. Or metastatic disease from somewhere else entirely.
So the workup has to be highly purposeful.
Mm-hmm.
For our patient, we noted there's no continuity with the thyroid, which pretty much pushes goiter down the list.
Good.
Then you ordered germ cell tumor markers, right? So alpha-fetoprotein and beta-HCG.
And those come back completely normal.
Yep, completely normal. And there's no bulky adenopathy elsewhere in the chest or the neck that would, scream lymphoma. But the biggest clue is that symptom we mentioned earlier.
The double vision.
Right, the diplopia and the heavy eyelids, the pitosis.
Which is just the classic presentation of myasthenia gravis. It's a paraneoplastic syndrome intimately tied to thymoma.
Walk me through the actual biology there, because it is fascinating. How does a physical mass in the chest cause a patient's eyelids to droop at 5 o'clock in the afternoon?
Well, it really comes down to what the thymus actually does. The normal thymus is essentially the schoolhouse for your immune system's T cells.
It's teaching them.
Right. It teaches them to recognize foreign invaders without attacking your own body. But when a thymoma develops, the neoplastic epithelial cells in the tumor, they basically alter that educational environment.
The schoolhouse goes rogue.
That's a great way to put it. It starts releasing these miseducated T cells that produce autoantibodies. And in myasthenia gravis specifically, those antibodies target and attack the acetylcholine receptors at the neuromuscular junction.
Wow. So the nerves are still firing, trying to tell the muscles to contract, but the chemical signal just gets blocked at the receptor level.
Correct. And because acetylcholine gets depleted with repeated muscle use over the day, the weakness is fatigable.
So they might wake up fine.
Exactly. They wake up feeling completely normal, but by the evening, their ocular, bulbar, or respiratory muscles are just failing. This is why every single patient with a suspected thymoma needs a deliberate, targeted neurologic history.
You can't just casually ask, hey, do you feel weak?
No, not at all.
Yeah.
You have to specifically ask about double vision, difficulty swallowing, changes in their voice, and shortness of breath.
Which brings up a critical safety issue. If our patient has myasthenia gravis, We can't just casually schedule them for a surgical biopsy next week, right?
Oh, that would be a potentially lethal mistake.
Lethal, really?
Yes. The physiological stress of surgery, combined with the muscle relaxants they use in general anesthesia, can actually trigger a myasthenic crisis. The patient could lose the ability to breathe on their own and end up completely ventilator-dependent in the ICU.
Wow.
So if you even suspect myasthenia, you must bring in neurology and achieve strict medical control. Often that means acetylcholinesterase inhibitors, immunosuppressants, maybe IVI, but you do that long before anyone brings that patient near an operating room.
Okay, so let's say we've done that. Neurology came in, they optimized the patient, the myasthenia is tightly controlled.
Good.
Here's where I struggle, though. Because every instinct I have from treating lung cancer or breast cancer or colon cancer tells me that tissue is the issue.
Right, the classic oncology reflex.
Exactly. We're taught that the very first step is to stick a needle in the tumor and get a histologic diagnosis. But the thoracic surgeons get incredibly defensive when I suggest a transpleural core biopsy for a resectable thymoma. Why is that such a taboo?
Because in this specific context, the biopsy decision is actually a treatment decision. The instinct to demand diagnostic certainty before surgery is totally logical in lung cancer, but in thymoma, it completely ignores the mechanics of the pleural space.
Okay, how so?
Well, the pleural cavity operates on negative pressure. When you drive a needle through the chest wall, across the pleural space, and into the capsule of a thymoma, you are creating a track.
Oh, I see where this is going.
Right. When you withdraw that needle, you risk dragging neoplastic cells out of that encapsulated tumor and literally shedding them into the pleural cavity.
You are essentially seeding the pleura. You take a disease that was neatly contained in a biological envelope, and by just trying to diagnose it, you turn it into a pleural disaster.
You've just converted a potentially curable localized stage I or II tumor into a devastating stage I of a clinical scenario with pleural drop metastases.
That is terrifying.
It is, and that is exactly why the cardinal rule for a strongly suspected, localized, and anatomically resectable thymoma is to avoid a transpleural biopsy. The surgeon will take the patient to the operating room for a total thymectomy, and that operation serves as both the definitive diagnostic procedure and the primary therapeutic intervention.
I understand the mechanics now. But, medicine is never full of absolute rules. Under what circumstances would you actually order a core biopsy?
You basically reverse the clinical picture. Let's say the multidisciplinary team looks at the scans and the surgeon says, look, I cannot achieve a complete surgical resection.
Or maybe the mass is highly atypical.
Exactly. If it's invading extensively into the chest wall, or if there is already bulky mediastinal adenopathy suggesting lymphoma. In those cases, the patient is likely heading down a non-surgical or neoadjuvant pathway involving chemotherapy or definitive radiation.
And to prescribe those therapies, you absolutely need tissue.
Right. But even then, the interventional radiologist or the thoracic surgeon will use an approach like an extrapleural peristernal route. They meticulously avoid crossing the free pleural space if ecmoma is still anywhere on the differential.
Okay, so for our patient with the controlled myasthenia and the localized prevascular mass, we just skip the transpleural biopsy. The surgeon evaluates them and determines that a complete R0 resection is anatomically feasible.
Perfect.
But this forces us to confront staging. And I have to say, staging thymoma feels like trying to read a textbook where the chapters keep switching languages mid-sentence.
That is a perfect analogy. You really do have to be a clinical translator. You have to be bilingual.
Right.
Today, for the modern medical record, you must document the current clinical stage using the AJCC TNM system, which, is currently on version 9. But almost all the foundational historical evidence that dictates whether we actually use postoperative radiation was written using the Masaoka or Masaoka-Koga staging systems.
Let's break down why that's so complicated for people. The Masaoka system originated in the early 1980s, and it was primarily a surgical and pathologic staging system, right?
Yeah, it was based heavily on what the surgeon literally felt with their hands and what the pathologist saw under the microscope regarding capsular invasion.
So Masaoka stage, I meant completely encapsulated. Stage 2 meant microscopic capsular invasion or macroscopic invasion into the surrounding mediastinal fat.
And then stage 3 meant direct invasion into neighboring organs like the pericardium, lungs, or major blood vessels. Stage 4 meant pleural or pericardial dissemination or distant metastasis.
But the issue is that the world has moved to the AJCC TNM system, which is heavily anatomically driven.
Let's quickly review the current AJCC version 9 T stages, so we have that modern anatomy fresh in our minds.
Okay.
Think of the tumor as radiating outward from the center of the chest. T1 disease is relatively contained. It's limited to the thymus itself, or it only involves the anterior mediastinal fat or the mediastinal pleura.
And they split that by size, right?
Yeah.
T1A is 5 centimeters or smaller, and T1B is larger than 5 centimeters.
Exactly. And as it pushes into the immediate neighbors, the T stage increases. T2 is direct invasion of the pericardium, the lung parenchyma, or the phrenic nerve.
Then T3 involves deeper vascular invasion, the brachiocephalic vein, the SVC, the chest wall, or the extrapericardial pulmonary arteries or veins.
And T4 is the most aggressive local invasion. That's hitting the high rent district, the aorta, the arch vessels, the intrapericardial pulmonary vessels, the myocardium itself, the trachea, or the esophagus.
The nodes are simpler, at least. N1 refers to the anterior or parathymic nodes right in the neighborhood, and N2 refers to the deep intrathoracic or cervical nodes.
And for metastasis, M1A covers separate pleural or pericardial nodules, while M1B is a distant intraparenchymal lung nodule or metastasis to other organs.
But here is the trap we see all the time in tumor board. A radiologist looks at the preoperative contrast-enhanced CT, points to the mass pressing against the pericardium, and just casually calls it T2 invasion.
And that is a fundamental imaging pitfall. Abutment on a CT scan does not equal pathological invasion.
They just look like they're touching.
Right. When you look at the imaging, you might see a complete loss of the fat plane between the tumor and the pericardium, or the superior vena cava. That absolutely raises your index of suspicion. But a CT scan often cannot distinguish between a tumor that is merely compressing a structure, a severe desmoplastic inflammatory reaction, or true malignant cellular invasion into the tissue wall.
I see that constantly. The surgeon goes in, expecting to have to resect a massive portion of the pericardium based on the scan. But the tumor simply peels off easily.
Which is why, when you are looking at the preoperative imaging, the disciplined approach is to acknowledge the contact, but wait for the operative and pathologic findings to define the final T stage. Now, if you see frank vessel encasement, obliteration of the lumen, or tumor actually growing inside a vein, your confidence in true invasion goes up. But contact alone is just contact.
This really highlights a crucial distinction that trips up a lot of junior clinicians. And that's the difference between medical operability and anatomic resectability, because they are not the same thing.
Not at all. Medical operability is an assessment of the host.
The patient themselves.
Exactly. Can this patient's cardiopulmonary system handle the physiological insult of general anesthesia, single lung ventilation, and major thoracic surgery? Is their myasthenia neurologically stable enough to prevent a perioperative crisis?
Whereas anatomic resectability is an assessment of the tumor geometry.
Right, it asks, can the surgeon physically achieve an oncologic R0 resection, meaning absolutely no microscopic tumor left behind?
And the surgeon has to weigh that R0 goal against the functional devastation they might cause by chasing it, right? Like taking a piece of the pericardium or a wedge of the lung to get a negative margin is pretty standard. They might even sacrifice one phrenic nerve if the tumor is deeply invading it.
Yes, but they must carefully avoid bilateral phrenic nerve sacrifice.
Because the phrenic nerves control the diaphragm.
Exactly. If you resect both of them, both sides of the diaphragm are paralyzed. The respiratory morbidity is profound, and the patient may end up permanently ventilator dependent. So the surgical goal is a total thymectomy with complete excision of all contiguous disease, but they have to preserve at least one functioning phrenic nerve to maintain the patient's quality of life.
And while they're in there navigating that complex anatomy, we, as radiation oncologists, desperately need them to leave breadcrumbs.
Yes. They need to place surgical clips.
Clips are just non-negotiable in modern thoracic surgery. But it isn't just about dropping a handful of metal randomly into the chest.
No, the surgeon needs to place clips specifically at areas of close margins, areas where they know they left residual disease, or areas where the tumor was stubbornly adherent to a structure they couldn't safely resect. Those clips are our roadmap later.
Okay, so the surgery is finished. The patient recovers beautifully. Now, the pathology report lands on our desk, and we transition into the postoperative decision matrix. Do we offer postoperative radiotherapy or PORT-T? This is arguably the most fiercely debated topic in thymic malignancies.
It is debated because the evidence is historically messy. But to navigate it, you have to start with the foundational rule. The surgical margin drives the dose and the decision.
Period.
If you are discussing a postoperative thymoma case and you talk extensively about the stage but fail to explicitly state the margin status, your clinical reasoning is fundamentally flawed.
Let's define the margin terminology clearly just to be sure. R0 means complete resection. The pathologist sees a buffer of healthy tissue around the entire tumor. R1 means microscopic residual disease. The surgeon thought they got it all, but the microscope shows tumor cells sitting right on the ink of the cut edge.
And R2 means macroscopic residual disease. The surgeon knew they had to leave a visible piece of the tumor behind, perhaps stuck to the aorta.
So let's look at the R0 category first, because that is where the controversy lives. If the patient has a Mazuoka stage I thymoma completely encapsulated and an R0 resection, everyone agrees, right? Observation is the standard of care.
Yes, the local recurrence rate there is incredibly low. Postoperative radiation just adds toxicity with no measurable survival benefit.
But then we hit Mazuoka stage 2. The tumor invaded into the surrounding mediastinal fat, or microscopically into the capsule, but the surgeon still achieved an R0 resection. I hear colleagues argue this both ways with absolute conviction.
Oh, all the time.
One will say, stage 2 disease always gets radiation. That's standard. And another will look at the exact same pathology report and argue, the margin is R0, there is no tumor left. Radiating an empty bed is medieval. How do we reconcile this?
You reconcile it by recognizing that both of those dogmatic positions are overconfident and unsupported by modern nuance. The historical data driving the stage 2 debate is almost entirely retrospective, and retrospective databases are deeply vulnerable to selection bias.
Right, because historically, surgeons likely referred the worst-looking stage 2 cases for radiation, the ones where the fat was heavily involved or the tumor was particularly bulky, and they just observed the favorable ones.
Exactly. So when you look back at the database decades later, the radiation group doesn't look like it had a huge survival advantage simply because they started with more aggressive disease.
Plus, those retrospective studies span decades.
Decades of mixed histologers, variable surgical techniques, inconsistent staging interpretations, and older radiation technologies that delivered massive toxic doses to the heart and lungs. Mandating radiation for every stage 2 patient is an unsupported universal rule.
But assuming an R0 margin guarantees local control is also naive.
Yes. So how do you actually make the decision when that patient is sitting in your consultation room?
Right, what's the actual calculus?
You have to individualize the risk by breaking the pathology report apart. First, what exact structure was invaded? Invasion into a robust fat pad is very different from invasion that was a millimeter away from the phrenic nerve.
That makes sense.
Second, what is the histology? Thymomas are classified by the World Health Organization, the WHO classification. Type A, B, and B1 are generally indolent. But type B3 is composed of atypical epithelial cells. It behaves much more aggressively, bordering on thymic carcinoma.
So if I see a WHO type B3 histology, my threshold to recommend radiation drops significantly.
Exactly. And you have to weigh the oncologic benefit against the geometric cost. Let's say you have a 35-year-old patient. The mass was centered low in the anterior mediastinum. If you radiate that bed, you are going to expose a massive portion of their anterior heart, including the left anterior descending coronary artery, to radiation.
And the potential for a radiation-induced myocardial infarction 20 years down the line might absolutely outweigh a theoretical 10% reduction in local recurrence.
That is the exact clinical calculus. A marginal indication for radiation should be judged very differently in a 35-year-old patient with a massive cardiac toxicity risk compared to a 75-year-old patient where local progression in the chest is the most immediate dominant threat to their life.
Now, what if the margin is positive? Let's say the pathologist finds microscopic disease right on the margin and R1 resection.
An R1 margin changes the conversation entirely. Microscopic residual disease in the mediastinum has a high rate of local recurrence. Postoperative radiation is a strong established pathway here.
What dose are we talking?
We typically prescribe doses around 54 gray to sterilize that microscopic disease.
And if the margin is R2, say the surgeon had to leave a visible chunk of tumor on the superior vena cava.
An R2 resection is no longer an adjuvant situation. You must treat that as gross residual disease. You are shifting to a definitive dose strategy, typically escalating to 60 to 66 gray, or even higher if the organs at risk allow it.
And because of the high risk of failure, you strongly integrate systemic therapy discussions with medical oncology, right?
Absolutely.
We also need to pause here and draw a massive line between thymoma and thymic carcinoma. We've been using them almost interchangeably, but biologically they're distinct entities.
They're completely different beasts. Thymoma, even when locally aggressive, often retains some organotypic features of the thymus, which is exactly why it generates those paraneoplastic syndromes like myasthenia gravis. Thymic carcinoma, however, has lost that architecture.
It's just a frankly malignant, poorly differentiated cancer.
Right. It rarely, if ever, presents with myasthenia.
In fact, if a patient is referred to you with a presumed diagnosis of thymic carcinoma, but they have classic fatigable weakness and double vision, your alarm bells should be ringing.
Loudly.
That discordance means you need to get the pathology slides reviewed by an expert thoracic pathologist immediately, because the biology just doesn't match the clinical syndrome.
And because thymic carcinoma is so much more biologically aggressive, it has a significantly higher tendency for nodal spread and distant dissemination. Therefore, the argument for postoperative radiation strengthens much more quickly for thymic carcinoma than it does for thymoma, even in earlier stages with R0 margins.
Right, so let's say the multidisciplinary decision is made. We have a patient with an R1 microscopic positive margin, and we are going to deliver 54 grays. Now we are sitting at the treatment planning workstation. This is where the physical execution has to match the clinical intent. I love this phase because we use a specific discipline here. Reconstruction over contouring.
That concept is critical. If you sit down at the workstation and just start contouring the soft tissue you see on the postoperative CT scan, you are going to miss the target.
Because the anatomy has been fundamentally altered by the surgeon.
Entirely. The thymus is gone. The pericardium might have been partially resected and reconstructed with synthetic mesh. The lungs inflate differently into that empty space. The heart might have shifted. If you only look at today's scan, you are essentially guessing.
Which is why we use the POPC mnemonic to reconstruct the actual risk bed. POPC.
The first P stands for preoperative imaging. You must rigidly fuse the preoperative CT or MRI to your planning scan. You need to see exactly where the tumor lived in three-dimensional space relative to the spine and the sternum before the anatomy shifted.
Right. And the O is the operative report. You can't just skim the conclusion. You have to read the surgeon's narrative. Where did they struggle? Did they note that the tumor was densely adherent to the left brachiocephalic vein? Did they have to scrape it off the pleura?
The second P is the pathology report. Did the invasion happen anteriorly into the sternal fat or posteriorly toward the great vessels? The microscopic details dictate exactly where you need to push your radiation dose.
And finally, the C stands for clips. But clips only matter if you actually know what they mean. Treating clips without knowing what they mark is a massive failure mode.
Oh, it is a classic error. The surgeon might have placed clips to mark a feeding vessel they ligated, or they might have placed them to mark a frankly positive margin. If the operative report doesn't clearly distinguish between a safe dissection plane and an area of gross residual disease, you have to pick up the phone and call the surgeon.
You can't just guess.
No. A beautifully conformal, highly modulated radiation plan can be precisely mathematically wrong if your clinical reconstruction of the target is flawed.
Let me ask you about a temptation a lot of us face. We're dealing with a rare disease, the stakes are high, and the mediastinum is a very complex space. Why shouldn't I just design a massive radiation field that treats the entire anterior mediastinum and covers the bilateral supraclavicular lymph nodes electively? Isn't it safer to just blanket the whole area?
That is the reflex of fear, and you have to strongly suppress it. Extensive elective nodal irradiation is not standard for thymoma. The lymphatic drainage of the thymus is different from the lungs, and regional nodal spread in early to intermediate thymoma is incredibly uncommon, often less than 5%.
So you're exposing the patient to significant esophageal toxicity, lung toxicity, and cardiac risk for a failure pattern that rarely even happens.
Exactly. You build your radiation field strictly around the reconstructed POPC risk bed, not a generic historical box field. Even for thymic carcinoma, which does have a higher propensity for nodal involvement, any nodal coverage should be justified by the actual disease presentation on imaging and the surgeon's evaluation, not just a blanket assumption.
And targeting that reconstructed bed is complicated by motion. A mediastinal mass is not a peripheral lung nodule sitting quietly in the periphery. It is resting right on top of a beating heart, and it moves with every breath the patient takes.
Which means a 4D CT scan or another documented method of motion assessment is absolutely essential. You have to capture the full respiratory cycle to ensure your target volume actually covers the tissue as it moves. And when you evaluate the radiation plan, you must rigorously protect the organs at risk.
We generally think of organs in two categories, right? Serial and parallel. You have to protect the serial organs, the spinal cord, the esophagus, the central airways. A high-dose focal error in a serial organ can cause a catastrophic failure, like a spinal cord injury leading to paralysis or a severe esophageal stricture.
And you evaluate the lungs and the heart as parallel organs. This brings us back to the survivorship horizon. Many thymoma patients are young. If a 40-year-old survives their thymoma, they have 40 more years for radiation-induced heart disease to manifest. You must keep the heart dose as low as reasonably achievable, the LARA principle.
And we can't just look at the mean heart dose and feel good about ourselves. A low average dose across the entire heart doesn't make the plan safe if there is a massive 60 gray hotspot sitting directly on the left anterior descending coronary artery.
That is a phenomenal point. You have to review the specific cardiac substructures. If the anatomy forces a high dose to critical cardiac vessels, you must evaluate advanced delivery techniques. This is a scenario where proton therapy is often deeply investigated.
Because of the Bragg peak.
Exactly. The Bragg peak of protons can allow you to cover the anterior mediastinal bed while depositing zero exit dose into the posterior heart and lungs.
Okay, so we've built a robust, biologically sound pathway for our thymoma case. But what happens when the pathology report throws us a complete curveball? What if the biopsy or the resection comes back as something totally unexpected? This brings us to the stress test of rare thoracic tumors. Because the most dangerous thing a clinician can do here is rely on the rule of extrapolation.
The rule of extrapolation is a major cognitive trap. It happens when a clinician encounters a rare disease, panics slightly, and just reflexively borrows the treatment algorithm from a common disease that sounds vaguely similar.
Which is a terrible idea.
To combat that, I teach an 8-step discipline when facing an unusual thoracic histology.
Let's walk through that discipline because it really forces a pause. Yeah. Step 1. Confirm the anatomic site of origin. Is this actually a primary mediastinal tumor, or is it a metastasis from an occult primary somewhere else?
Step 2. Mandate an expert pathology review. Rare tumors often require highly specific, entity-defining immunohistochemistry or molecular tests that community pathology labs may not routinely perform.
Step 3. Explicitly name the staging system and addition you are using. Do not just borrow lung cancer TNM by habit and assume it applies.
Step 4. Separate medical operability from anatomic R0 resectability. We discussed this deeply, but it bears repeating.
Step 5. State your treatment intent out loud to the team. Are we treating this for cure? Is this consolidative therapy? Are we salvaging a recurrence? Or are we purely palliative?
Step 6. Identify the dominant threat. Is the main risk local invasion into the heart, regional nodal spread, pleural dissemination, or distant brain metastasis? The dominant threat dictates your primary weapon.
Step 7. Use disease-specific evidence when it actually exists. And if you are forced to extrapolate from another disease, explicitly acknowledge out loud to the multidisciplinary team that you are guessing based on a proxy.
And step 8. Build your radiation target around the actual failure compartments and the specific organs at risk for that exact disease.
Let's apply that discipline to a real stress test. Thymic neuroendocrine tumor. The word neuroendocrine instantly makes every oncologist think of small cell lung cancer.
And that is the massive trap. Thymic neuroendocrine tumors arise from a completely different embryological origin than small cell lung cancer. The diagnosis requires confirmation of thymic origin and specific grading. You have typical carcinoids, atypical carcinoids, small cell carcinomas of the thymus, and large cell neuroendocrine carcinomas. They do not share the same natural history.
So if a clinician hears neuroendocrine and reflexively imports the small cell lung cancer pathway, like ordering prophylactic cranial irradiation to the brain and prescribing generic small cell chemotherapy protocols, they are making a massive biological error. Thymic neuroendocrine tumors have a very different propensity for brain metastasis compared to lung primaries.
Another brilliant stress test is NUT carcinoma. This is a rare, devastatingly aggressive malignancy. The diagnosis requires the demonstration of a specific genetic event, an NUTM1 rearrangement, often a BRD4 NUT fusion, or convincing NUT immunohistochemistry in what basically looks like a poorly differentiated carcinoma.
That fusion gene essentially blocks the cells from differentiating. They just stay in this primitive, hyperproliferative state. It is lethal in months, if not managed aggressively.
And the trap here is that it often looks like a generic squamous cell carcinoma under the microscope initially.
Yeah.
If you just treat it like an ordinary squamous cell lung cancer with standard chemotherapy, the disease will rapidly progress right through your treatment.
Wow.
Once NUT carcinoma is established, there is zero justification for applying a generic algorithm. The safe pathway requires comprehensive staging and immediate referral to a highly specialized center with access to clinical trials or targeted epigenetic therapies.
Discipline over reflex.
And wrestle.
Every single time. So let's pivot to the final phase, surveillance. We've navigated the workup, the surgery, the radiation, and the rare pathology. The patient is successfully treated. How do we follow them over time?
Surveillance is dictated by the natural history of this specific histology. Thymoma is notorious for late recurrences. It can come back 8, 10, or 12 years after the initial surgery. Therefore, for a completely resected stage IR0 thymoma, a practical schedule is a contrast-enhanced chest CT every 6 to 12 months for the first 2 years, and then annually all the way out to year 10. For other, more advanced thymoma presentations, you tighten that up. A chest CT every 6 months for the first 2 years, then annually to year 10.
But because thymic carcinoma is far more biologically aggressive, the recurrence pattern is shifted earlier. The schedule has to reflect that early threat. For a stage IR0 thymic carcinoma, it's a CT every 6 to 12 months for 2 years, then annually out to year 5. For other treated thymic carcinomas, it's highly aggressive, every 3 to 6 months for the first 2 years, then annually out to year 5.
Now let's distill this entire discussion into 6 actionable board pearls.
I'll take the first one. Pearl 1. A provascular mass is a compartment diagnosis before it is a radiation diagnosis. Rely on imaging patterns, negative germ cell tumor markers, and syndromic clues like myasthenia gravis to guide a deliberate pathology strategy.
Pearl 2. In a strongly suspected resectable thymoma, avoid routine biopsy and absolutely avoid a transpleural route. Surgery serves as both the diagnostic and therapeutic procedure when an R0 resection is feasible, protecting the pleural space from catastrophic seeding.
Pearl 3. You must be bilingual in staging. Document the current clinical stage using AJCC version 9, but explicitly name Sayoko or Masaoka Koga when interpreting the historical postoperative evidence. And remember, imaging contact on a CT scan is not the same as true pathologic invasion.
Pearl 4. Medical operability and anatomic resectability are entirely separate assessments. The surgical margin status then dictates everything else, completely separating the R0 observation or controversy pathways from the R1 and R2 definitive radiation pathways.
Pearl 5. Postoperative planning requires the clinical reconstruction of the true risk bed using the POPC mnemonic pre-op imaging, operative report, pathology, and clips. It is not the automatic irradiation of the entire mediastinum. You must assess motion and rigorously protect the heart and lungs.
Pearl 6. For any rare thoracic tumor, reject the rule of extrapolation. Confirm the origin and pathology, use the correct staging system, state your clinical intent, identify the dominant failure risk, and seek specialty review before blindly applying common lung cancer algorithms.
Which brings us to the final test of our clinical logic, the board blitz. 3 rapid-fire questions to solidify the mechanisms we've discussed. Question 1. An adult patient presents with a well-defined mass in the thymic bed. There is no continuity with the thyroid, germ cell markers are negative, and there is no other adenopathy. An experienced thoracic surgeon reviews the imaging and believes that R0 complete resection is feasible. During the history, the patient reports intermittent diplopia and fatigable weakness late in the day. What is the most appropriate best next step? A. Transpleural core biopsy. B. Definitive radiation therapy. C. Evaluate and control myasthenia. Complete the operability assessment and proceed toward total thymectomy without a routine biopsy. Or D. Observe with annual imaging.
The answer is C. This is a classic, high-probability resectable thymoma presentation. The symptoms strongly suggest myasthenia gravis, which requires immediate neurologic evaluation and strict medical control to prevent a perioperative crisis. Because an R0 total thymectomy is anatomically feasible, surgery is the primary curative pathway. It establishes the diagnosis safely without risking pleural drop metastases from a transpleural biopsy.
Excellent. Question 2. A patient undergoes a total thymectomy, and the final pathology reveals a thymoma with an R0 resection, completely negative margins. The operative and pathology reports describe local invasion into the mediastinal fat, consistent with the Masaoka stage 2 presentation, but the exact microscopic risk features in WHO histology aren't entirely clear yet. What is the best recommendation? A. Mandatory postoperative radiation for all stage 2 disease. B. Mandatory observation because the margin is R0. C. Review the exact invaded structure, margin confidence, WHO histology, competing risks, and potential heart and lung dose, then individualize a decision. Or D. Treat the entire mediastinum and bilateral supraclavicular regions electively.
The answer is CR0 stage 2 thymoma represents a genuine controversy driven by conflicting retrospective evidence prone to selection bias. You cannot ethically mandate radiation for all of these patients, as it may expose young patients to unjustified cardiac toxicity. Conversely, you cannot mandate observation without acknowledging the risk of local failure. You must individualize the decision based on specific local risk features like WHO type B3 histology, the proximity to critical structures, and the anticipated toxicity of the radiation plan.
Spot on. Question 3.
You are reviewing a postoperative radiation plan for a patient with an R1 microscopically positive margin thymoma. The plan covers only the surgical clips, fails to use a preoperative scan, treats the entire mediastinum electively, utilizes no 4D CT motion assessment, and delivers a massive dose to the anterior heart and bilateral lungs. What is the best clinical response? A. Approve the plan because an R1 margin means target coverage matters more than toxicity. B. Reduce the total dose but maintain the large field size. C. Reconstruct the true tumor bed using POPC, remove the unjustified elective nodal coverage, assess respiratory motion, and reoptimize to spare the heart and lung exposure. Or D. Omit radiation entirely because the target cannot be reliably reconstructed.
The answer is clearly C. An R1 microscopic positive margin is a strong established indication for postoperative radiation, typically to around 54 gray. However, that indication does not excuse a poorly reconstructed target or avoidable massive organ exposure. Broad cardiac and pulmonary dose is never an acceptable substitute for disciplined clinical reconstruction. You must use the pre-op imaging, assess motion, and eliminate unnecessary elective nodal fields.
As we wrap this up, if there is one final provocative thought you want to leave ringing in the listener's ear regarding rare thoracic tumors, what is it?
It is really about survivorship and the reality of retreatment. Because the natural history of thymoma can be incredibly indolent, patients often survive for decades. But if a patient recurs 8, 10, or 12 years later, do not reflexively repeat the initial treatment pathway. If they recur in the pleura, which is common, remember that an isolated pleural recurrence in thymoma is not an automatic death sentence.
It's not like other metastatic cancers.
Exactly. It is fundamentally biologically different from rapidly disseminated extrathoracic metastatic disease. Retrieve their prior radiation plan, reconstruct their cumulative organ constraints, and realize that focal salvage therapy, whether that is a repeat surgical resection or highly targeted SBRT, can still be curative. You must treat the patient's actual tumor biology, not just the timeline of their recurrence.
In episode 26, we will turn to pleural mesothelioma and separate post-pneumonectomy one lung planning from lung-sparing two lung treatment without blurring their very different risks. Get show notes and complete practice oral boards at radonsmartlearn.com and subscribe for our next episode. Thanks for tuning in.